Okay, well, I think we'll get started. So my name is Claire Healy. I'm one of the managers in the Smilow Cancer Genetics and Prevention Program, and we're very excited to have all of you join us tonight. This is a 2-night seminar series, and we've titled it Identifying and Caring for Individuals with High Risk and Inherited Cancer Syndromes. And the goal of this seminar series is really to help provide some information to our colleagues in the community on how to recognize patients at elevated risk to develop cancer and those who may have an underlying hereditary cancer risk. So we'll be utilizing the Q&A feature for questions. So feel free to type your questions in as the talk goes on. And we will plan to have a question and answer session at the end with our speaker. So I'll introduce our speaker and then turn things over to her. So tonight we're pleased to welcome Amy Killie. And Amy received her master's degree in genetic counseling from the Icahn School of Medicine at Mount Sinai. She's been with the Smilow Cancer Genetics and Prevention Program for 4 years, and she's one of our more experienced counselors at a genetic counselor 2 level. And her research interests include hereditary pancreatic cancer. So we're thrilled to have Amy. And Amy, thank you for joining us. I'll turn it over to you.
Great. Thanks so much, Claire, for the introduction. Good evening, everyone. I'm very excited to be talking to you about hereditary cancer and things to look for and things to consider when thinking about a referral to hereditary cancer. So I am just going to share my screen.
Amy, I'm not seeing your slides.
Yep, I just put it on pause just for one.
Okay.
And these things always take a second, don't they? Okay.
There we go.
Everyone can see them now. Okay, great. Okay, perfect. So just for the agenda today, what I want to go over is I want to review referral guidelines for hereditary cancer. I want to review the more common hereditary cancer indications. Then I want to review a couple of more rare hereditary cancer indications, then talk about self-pay genetic testing and also direct-to-consumer genetic testing, and talk about some of the practical aspects of genetic testing, why someone may want to have genetic testing, and talk about genetic counseling as a whole. So to start talking about hereditary breast cancer, so we cannot talk about hereditary cancer without talking about BRCA1 and BRCA2 related to hereditary breast and ovarian cancer syndrome. These genes are probably the poster children of hereditary cancer testing, and I know that everyone here has heard about them before. As we know, they make up mutations in these genes. Germline mutations in these genes are associated with a high risk of breast cancer in women, which slightly dependent on BRCA1 or BRCA2, but the risk is between 50 to 75% lifetime risk, and also a significantly increased risk of ovarian cancer in women with, again, a range depending on the gene, but between 15 up to 60% lifetime risk. So definitely significant lifetime risks. And I mentioned these genes are the poster children of why we do genetic testing, is that even though these are considered to be high risk genes, there are management guidelines. There's screening options for women who test positive for a mutation, BRCA1 and BRCA2, in terms of beginning breast imaging at a younger age, adding on breast MRI for more sensitive imaging, prophylactic bilateral mastectomies, I feel like are often talked about in the media. Everyone's heard of Angelina Jolie. So that is an option women decide to pursue. And of course, prophylactic bilateral self-lingual oophorectomy to be preventative against ovarian cancer. So in the advent of genetic testing for these genes and establishing guidelines, you know, women and other people who are at higher risk of hereditary cancer have really been able to take this information and use it to actually lengthen their life and have a better quality of life. So really, we can't talk about hereditary cancer without talking about these two genes. However, we are now past the era of only testing BRCA1 and BRCA2. It's not uncommon for me to see a patient and say, oh, I'm here for the BRCA test. But now, especially since about 2015, now our testing includes many other genes that we now know of relating to hereditary risk of breast cancer. And we know that these genes, they can be arranged. So some of these broke up in little categories, but BRCA1 and 2 are considered a high risk breast cancer gene. And there's other genes that fall into that category as well that also have guidelines. Now, some of these higher risk genes often have other features that are uncommon or more rare. For example, the gene TP53, many people have heard of, related to Lynch syndrome, which is most characteristic of early onset sarcomas or early onset osteosarcomas, very young breast cancer, and childhood cancers. So not every single high risk gene is necessarily a gene of interest for a woman who has early onset breast cancer, but with the advent of larger testing, we can now test for these genes all at the same time. And what we now know is there are other genes that fall into more of the moderate risk, which would be ATM and CHEK2. You can see in the middle in the blue column there, the risk ranges between 20 to 40% lifetime risk. You can see in the high risk category, PALB2, which has been in the news more recently. We've been getting a lot of messages about PALB2, which we consider to be a moderate to high risk breast cancer gene, which is why it's in the high risk category, where the risk can be upwards of 58% lifetime risk. So there are other genes that we definitely want to be testing individuals for if they have a family history that's concerning for hereditary breast cancer. And now you see in the green column, there are genes that have an unknown risk of breast cancer, because as we've studied genes and as we've learned more about genes, the risk is sometimes unclear, where there might be literature suggesting an increased risk of breast cancer, but maybe not enough to be significant, or more data is needed. So some of these genes are included on genetic testing. And this, again, just shows the range, specifically of, I would say, the major ones that we would test for, like ATM, CHEK2, PALB2, where the lighter blue is the higher end of the range and the darker blue is the lower end of the range. So you can see every gene is different, and that's why we're now past this era of only doing testing for BRCA1 and BRCA2, because these genes, some of them do have significant risks, and most importantly, we have guidelines for screening. Now, this is sometimes a very common thing that we will see with patients. BRCA1 and 2 testing has been around for at least 20 years. So it's not uncommon for patients to say, oh, I've already had this test. I had this test in 2012. It was negative. So it's often common to see a test report like this. But back before, I would say definitely before 2014, and probably a little bit even before then, especially BRCA1 and 2 testing was really limited to sequencing only. And sequencing for BRCA1 and BRCA2 can detect up to 90% of detectable pathogenic mutations. And sequencing covers the clinically important regions of each gene, including the coding exons. So that is a very informative test, but sequencing cannot detect large deletions or duplications of BRCA1 and BRCA2. So it is important when a patient has had genetic testing to know what year was it, and to also confirm with records, because, for example, in this case, it says BRCA1 and BRCA1 sequencing, BRCA2 sequencing, no mutation detected, but this test would not include what we consider large rearrangement analysis, which is on, which you can see here, BRCA1 and BRCA2 full gene rearrangement, also sometimes called deletion duplication, which detects intragenic deletions and duplications at single exons. Some people also call this the BART test, because back until 2013, Myriad Genetics had the patent on BRCA1 and 2, So their actual test name for BRCA1 and 2 large rearrangement testing was BART. So some people you might hear patients talking about BART testing. You might hear about BART testing. BART is just a name that Myriad gave their own test for large rearrangement. But now that Myriad Genetics does not have the patent, there's many other labs doing this test. And nowadays it's standard of care when we do BRCA1 and 2 testing to do full gene sequencing and deletion duplication. So what's also important is that if a patient reports BRCA1 and 2 testing prior to 2013, one, it's possible they may have only had BRCA1 and 2 sequencing and not deletion duplication. But even if they had full gene sequencing and deletion duplication, updated genetic testing is likely to be indicated because prior to 2013, those other genes I had talked about related to hereditary breast cancer were not included on genetic testing, or at least very rarely included. So if patients before 2013 say that they had negative testing, it likely is worth a new referral to talk about updated testing. And I say 2013, but even patients that 2014, 2015, some of these bigger tests, these bigger panels were still coming into play. But I would say anything before 2013 is definitely worth a new evaluation. So I'm talking about hereditary breast cancer. So what should you be thinking about that would indicate a referral to cancer genetics if we're thinking about hereditary breast cancer? So our bread and butter for guidelines is NCCN guidelines based from the National Comprehensive Cancer Network. And these guidelines change every 6 to 12 months. Before it was focusing on just BRCA1 and BRCA2, but now in the advent of panel testing, moving past the era of just BRCA1 and BRCA2, we know there are other genes that someone would meet clinical guidelines for. So NCCN used to have a nice package of just BRCA1 and 2 relating to hereditary breast cancer, but now they've broken it up a little bit into hereditary breast cancer genes, hereditary ovarian cancer genes, hereditary pancreatic cancer genes, and hereditary prostate cancer genes. The reason for this is because mutations in BRCA1 and BRCA2 are related to hereditary breast cancer and ovarian cancer in women and breast cancer in men, but also they are related to prostate cancer risk in men and pancreatic cancer risk in men and women. So that's why NCCN has so many guidelines. And definitely it's not, these are, again, they change every 6 to 12 months. So you are not expected to be the expert on these guidelines. Again, as cancer genetics, we want to be a resource to you for your patients. So just to really distill some of these guidelines down and just some things to think about when placing a referral is that if someone with a diagnosis of breast cancer under 50, anything premenopausal, I will say, there is in blue for testing. If someone is at 50 or at 49 with no other family history, it's possible they may not meet their insurance guidelines. For testing to be clinically indicated and meet insurance guidelines, someone would need to be diagnosed at 45 or younger. But the reason why I say before 50 is because it is worth a referral, because sometimes there may be other factors that we would want to look into in the family, including small family size or limited structure, and also just to go through more distant relatives and take the time to go through a whole family history. Now NCCN guidelines is recommending genetic testing for anyone with triple negative breast cancer at any age. And triple negative breast cancer is breast cancer that tests negative for the estrogen receptor, progesterone receptor, and excess of the HER2 protein. So this means essentially that the growth of the cancer is not fueled by the hormones estrogen and progesterone, and is also not fueled by the HER2 protein. So triple negative breast cancer tends to be much harder to treat and more aggressive because it does not respond to hormonal therapy. So NCCN guidelines is now recommending triple negative breast cancer at any age, because triple negative breast cancer is more likely to have a hereditary component than triple negative breast cancer. For most insurance purposes, since insurance tends to be slower on the uptake than guidelines that change every 6 to 12 months, insurance won't cover testing and without any other family history unless someone's diagnosed at 60 or younger. So something to keep in mind, but in terms of a referral, it is definitely, I would say, indicated, so something that we can talk about with the patient. Anyone with ovarian, fallopian tube, or primary peritoneal cancer at any age is genetic testing is indicated. Men diagnosed with breast cancer at any age. Metastatic or intraductal prostate cancer diagnosed at any age. And this is a more, I would say, a newer development within the last 2 years, where there's been literature has suggested that men who have metastatic or prostate cancer that's more locally advanced, particularly if it's a higher Gleason score, which is used to rate aggressiveness of the prostate cancer, there is a higher prevalence of germline mutations in that group. So that's why for men with metastatic or intraductal prostate cancer, regardless of their age, genetic testing is indicated, particularly since it can be helpful in their own treatment options. Same thing with pancreatic cancer. This is a relatively new development since about 2019. I guess it's not so recent, but when I started, in order for pancreatic cancer to be someone to meet criteria, they would need additional family history, which is now not the case. Pancreatic cancer, based on newer literature, kind of similar to metastatic prostate cancer, is more likely to have a germline mutation than more common cancers. So given that, that's why pancreatic cancer at any age is clinically indicated for genetic testing, also because there is treatment options. And also, if there's 3 cases of the same cancer or associated cancers on the same side of the family, so someone who has breast cancer and 2 relatives with breast cancer, or someone with breast cancer and a cousin with ovarian cancer, a man with prostate cancer and his mother with breast cancer. So those cancers all in the family is, if you're seeing that, especially multiple generations, multiple relatives, is definitely worth a referral. And finally, someone who has multiple primary cancers, such as someone who has breast and ovarian cancer, and bilateral breast cancer may be worth a referral. Bilateral breast cancer, if there's no other family history, and depending on the age, it may not meet insurance criteria for genetic testing, but it is worth a referral just for us to fully flesh out the family history and talk about that with the patient. So this is similar to the previous slide, but for just those patients with only a family history of cancer, something to consider is someone who is Ashkenazi Jewish ancestry. 1 in 40 individuals of Ashkenazi Jewish ancestry will have a BRCA1 and BRCA2 mutation. There are 3 founder mutations that are seen very commonly in the Ashkenazi population. 95% of Ashkenazi Jewish individuals who have a BRCA1 or BRCA2 mutation will have one of these 3 mutations. So it is more common in the Ashkenazi population, while in the non-Ashkenazi population, the risk of a BRCA mutation is about 1 in 400. So it is significantly increased. What I will say is that without a family history of breast cancer, ovarian, prostate cancer, pancreatic cancer, the likelihood someone would have a mutation is still relatively low. And at this point in time, there's no recommendations for general screening of the Ashkenazi Jewish population without a family history. So it is something I think worth to consider for a referral, because at least then we can talk about with the patient, and we can go through the family history. But I do want to make that caveat. And kind of similar to the before slide, if someone has at least 3 breast cancers in the family, in their mother and their aunt and a cousin, again, clustered on the same side of the family, that is worth a referral. Someone who has a close relative with breast cancer diagnosed at 45 or younger is worth a referral. And someone who has a relative with ovarian cancer, if someone reports that their aunt had ovarian cancer, that individual does meet criteria based on family history. So same thing with male breast cancer, having an uncle or a father with male breast cancer is a referral is indicated. Pancreatic cancer in a close relative, particularly if specifically if it's a parent or a child or a sibling, that is worth a referral. And same thing with metastatic prostate cancer if it's in a close male relative. And finally, as before, any close relatives with a combination of the above cancer types. Again, if you're seeing in the same family, prostate, ovarian, breast, pancreatic, any combination of that, that is definitely worth a referral because those cancers all can be associated through a single gene mutation. Now, switching gears and going to hereditary colon cancer, kind of like with hereditary breast cancer, we cannot talk about hereditary colon cancer without talking about Lynch syndrome. Lynch syndrome is caused by germline mutations in one of the four mismatch repair proteins or deletions in the EpCAM gene. The risk is very dependent upon the gene. Especially in the last few years, we've actually realized that the lifetime risks specifically with mutations in PMS2 and MSH6 are quite different than the risks associated with MLH1 and MSH2. And that could actually be a whole talk in and of itself. So I'm not going to go into all the details of how they're different, but essentially the main cancer risks with Lynch syndrome is colorectal cancer and uterine or endometrial cancer, as you can see in this chart, which is mainly based on the high, I would say the more high penetrant genes, MLH1 and MSH2. But there are a risk of other types of cancers, including other GI cancers like cancer of the stomach, bile duct, cancer of the pancreas. We can also see ovarian cancer in women who have Lynch syndrome and cancer of the urinary tract like the bladder. And also individuals with Lynch syndrome can have sebaceous adenomas, which are very specific types of skin findings. So when we think about hereditary colon cancer, I often think about it in these two buckets, where one bucket is what we call non-polyposis syndromes, which essentially is mainly Lynch syndrome, maybe other hereditary colon cancer syndromes. This just means that someone is at a high risk genetically of colon cancer, but it's not necessarily because they're developing a large number of polyps. The polyps in Lynch syndrome are not numerous like with polyposis, but the polyps in Lynch syndrome do advance much faster than non-Lynch syndrome associated polyps. So non-polyposis syndromes, you would see a high risk of colon cancer, but not the high risk of numerous polyps. Polyposis syndromes are different because an individual would be genetically predisposed to developing large numbers of colon polyps. The type is dependent on the polyposis syndrome, and I will review those briefly on the next slide. But typically, the polyps tend to be numerous, usually over 10, and those numerous polyps was what's causing the increased risk of colon cancer. So hereditary polyposis syndrome, most people have heard about familial adenomatous polyposis or FAP, which is characterized by someone developing, in the classic form, developing hundreds, possibly up to 1,000 adenomatous colon polyps beginning at a very young age, usually in the 20s or even younger. And for the majority of individuals, if this was left untreated, it's with a total colectomy, the risk of colon cancer approaches 100%, even by age 40. So this is a significant polyposis syndrome. Attenuated, as the name implies, is attenuated, meaning that the polyps develop at a later age, and there can be a smaller number of polyps, usually over 12, over 20, up to 100 adenomatous polyps, usually beginning in the 30s or 40s, 50s. And we have seen a variety of even very attenuated forms, even in our own clinic. So there does appear to be some variability we're discovering. MAP can sometimes mimic attenuated FAP, but the only difference with that is that all the cancer syndromes I've talked about are autosomal dominant, meaning someone would need to inherit a single pathogenic variant in one copy of the gene. MAP is autosomal recessive. So for someone to have MAP, their parents would need to be carriers. And MAP can present in a similar way to attenuated FAP with, again, usually over a dozen polyps, up to 100 polyps, beginning in someone's 40s or 50s. MAP can sometimes present with a more mixed polyposis type where there's adenomas, but also non-adenomatous polyps like hyperplastic polyps and others. Putz-Jaeger syndrome is a rare syndrome. It presents particularly with polyposis of the small bowel. You can also see it in the colon, but the small bowel is the part that's mostly affected. They develop specific Putz-Jaeger's polyps. There's other features such as mucocutaneous pigmentation that's present in childhood around the lips, on the fingertips, even on the nostrils. And there is an also associated risk of breast cancer and pancreatic cancer. Juvenile polyposis syndrome is not related to the age of onset of polyps, because it's not necessarily mean someone develops polyps as a juvenile or a child, but these individuals develop specific types of juvenile polyps, and juvenile polyps they're not common types of polyps to have. So someone who presents with multiple juvenile polyps would warrant investigation for juvenile polyposis. And then there's other more newly described polyposis genes where there does appear to be some risk of polyposis, but how that presents exactly is less clear. So since there are those two buckets, so let's talk about some of the guidelines for the referral guidelines for hereditary colon cancer. So Lynch syndrome, and the guidelines on NCCN are a little bit more clear in terms of when to refer. I'm not going to go through all of this because I know it's a lot, and I'm going to again distill it down, but essentially it is based in a similar way to BRC1 and 2 based on the age of diagnosis and the number of people affected. Polyposis syndromes, the testing strategy can be, as you can see, branched off a lot. So just to focus on this part here, probably the most important thing to think about is the number of polyps. It says here over 20 adenomas. We sometimes are more conservative, and if we see more than 10 adenomas, it's worth a referral just to look at the family history. If someone has exactly 10, depending on their age, how many colonoscopies they've had. Again, adenomas are common, especially as people get older. So having a few or a couple adenomas does not mean someone has polyposis, but something to think about also is someone's age, also the size of the polyp. A young person with a very large adenomatous polyp, even with a single polyp, may still be worth a referral. But these are just our suggestions. So anyone with a colon or uterine endometrial cancer diagnosis under the age of 50, that would be specifically suspicious of Lynch syndrome, because we expect to see those cancers at younger ages. Any Lynch syndrome associated cancer that is microsatellite unstable or has abnormal MMR staining by immunohistochemistry. So here at Yale New Haven and often other places, they're now doing universal screening of colon and endometrial tumors, which is done through immunohistochemistry. So staining of the tumor to look for the presence or absence of MMR proteins. For individuals who have Lynch syndrome, if we would expect that those MMR proteins would actually be absent on IHC staining, and if those MMR proteins are absent, it actually results in microsatellite instability. So this is something that is on pathology. It would comment if there was loss or presence of these proteins, if there was microsatellite instability. And so the presence of MMR proteins would actually be reassuring, and it actually would reduce the risk of Lynch syndrome. But that's why any cancer with abnormal IHC, missing MMR proteins, regardless of age, warrants a referral. As I mentioned before, multiple or over 10 or early onset GI polyps, particularly in the colon, but also, again, I mentioned with Putz-Jaeger syndrome, If there are polyps of the small bowel, that can also warrant a referral. And specifically, I would say over 10 adenomatous or mixed histology polyps, meaning if someone had a mix of adenomas or other polyps like hyperplastic polyps, that would warrant a referral. Since hamartomatous and juvenile polyps are more rare polyp types, if we see, there's essentially a lower threshold for the number of those polyps. So seeing at least 5 of those polyps would warrant a referral. And Puss-Jaeger's polyps are a particular type of colon polyp or small bowel polyp. So if that is confirmed on pathology, at least 2, it definitely warrants a referral. I'm adding this here for diffuse gastric cancer. It's not necessarily related to hereditary colon cancer, but diffuse gastric cancer is a rare type of gastric cancer. And it actually can be related, it is related to, when it's hereditary, related also to risk of lobular breast cancer. So diffuse gastric cancer, again, is rare, is specific pathology, but definitely diagnosis under 50 would warrant a referral. And similar to BRCA1 and 2, if there's 3 cases of the same cancer, like 3 colon cancers, or colon, uterine, colon, stomach, bladder, stomach, colon, all in close relatives in multiple generations, looking for those associated cancers, that would warrant a referral. And similar for BRCA1 and 2, multiple cancers in one individual, such as someone who's had 2 colon cancers or someone who's had colon and endometrial cancer. For those patients with just a family history of cancer, again, as I mentioned before, someone with at least 3 colon cancers or Lynch syndrome associated cancers in 1st and 2nd degree relatives, so close relatives. At least 1 first-degree relative with colon or endometrial cancer under the age of 50. So if someone's parent had or sibling had colon cancer under 50 or uterine cancer under 50. And for 2nd or 3rd degree relatives with a combination of the above cancer types, again, looking for those patterns of cancer. So I'm sure everyone here, again, as I talked about, knows about BRCA1 and 2, Lynch syndrome, polyposis. I want to talk about a few of more rare indications that you may not come across, but just something I wanted to bring up as a rare indication. So hereditary paraganglioma and pheochromocytoma syndrome is very rare. And as the name implies, individuals are at increased risk to develop rare tumors called paragangliomas and pheochromocytomas. So they develop from specific nerve cells, the chromaffin cells, and paragangliomas develop along the paravertebral axis from the base of the skull to the pelvis. So they can show up in the head and neck, they can show up in the abdomen. Pheochromocytomas are a specific type of paraganglioma that is confined to the adrenal medulla. Both of these tumors can secrete catecholamines, specifically pheos almost always secrete these excess of hormones. So someone who has a pheochromocytoma can actually present with severe hypertension, flushing, sweating, heart palpitations. The majority of these tumors are benign, but some of them can be malignant, particularly for some of these hereditary predispositions. So it's something that's why if a patient presents with a sudden neck mass or a mass in the abdomen, or is complaining of episodes of sweating, fatigue, anxiety, anxiety, heart palpitations, it's something to think about, maybe a referral to endocrinology. Not saying that everyone that presents with that will have these tumors because they're very rare, but they are something that we do screen for, and we do see patients with these tumors because there is also screening for individuals who have a hereditary predisposition. Another more rare hereditary predisposition is hereditary hyperparathyroidism. And I think when people think of hyperparathyroidism, they may not initially think of hereditary cancer, because hyperparathyroidism is not a cancer diagnosis, of course. It's just an overactive parathyroid gland. But hereditary hyperparathyroidism can be related to other risks of tumors. So the most common form of hereditary hyperparathyroidism is multiple endocrine neoplasia type 1 or MEN1, where the individuals with MEN1 will develop hyperparathyroidism over 90% of the time by the time they are 50, usually when they're in their 20s or 30s, and they are at risk of other endocrine tumors of the endocrine system, such as neuroendocrine tumors of the pancreas, of the stomach, of carcinoids. So it is important when someone has particularly early onset hyperparathyroidism to actually evaluate if they possibly have MEN1 and possibly some of these less common forms of hereditary hyperparathyroidism, because it possibly could mean they might be at risk of other endocrine tumors. So those are just two examples, but just some of the other indications that, maybe may not immediately come to mind when we think about hereditary cancer, some of the more rare indications. Anyone with medullary thyroid cancer, adrenal cortical carcinoma, paragangliomas, pheochromocytomas, or retinoblastoma at any age warrants a referral, or anyone that has a close relative with any of these cancers. Anyone with any, again, rare or unusual tumors or physical findings. So there are specific skin findings that even if they're benign, they actually can be indicative of a hereditary cancer syndrome, such as sebaceous carcinoma or sebaceous adenomas, which we can see with Lynch syndrome, or tricholomomas, which we can see with Cowden syndrome, which is related to the P10 gene. Melanoma is common. The biggest risk factor for melanoma or any skin cancer is, of course, fair skin and sun exposure. But if someone's had multiple melanomas, usually over 3, especially if they're at a younger age, that would warrant a referral to cancer genetics to rule out a hereditary melanoma syndrome. Leukemia in children is unfortunately common, but if there are other rare childhood tumors, that would be an indication for a cancer genetics referral, such as, again, a retinoblastoma, a sarcoma, an osteosarcoma. Some tumors that are diagnosed in children can be indicative of a rare hereditary cancer syndrome. And anyone diagnosed with primary hyperparathyroidism before the age of 50 warrants a referral. Again, since the most common type of hyperparathyroidism, MEN1, hypercalcemia, which often is the first presenting sign that someone has hyperparathyroidism, because elevated parathyroid hormones causes an elevation of serum calcium. Almost all people with MEN1 will have hypercalcemia by the time they're 50. So if someone has hyperparathyroidism before they're 50, that could indicate that, it is important to rule out another predisposition. And I say this for the end because it's not a rare indication, but anyone that has reports a family history of a known mutation in any cancer gene, BRCA1, MLH1, PALB2, ATM, any cancer gene, in a cousin, even in a first cousin once removed. If someone is reporting that is a definite indication for genetic testing. And it is very important, if a patient is reporting that to you, that you do encourage them to get a copy of their relative's test results, because that can actually be really helpful in their own testing and actually ensuring their own testing is accurate. So let's talk about out-of-pocket genetic testing options and direct-to-consumer testing. So out-of-pocket genetic testing options, luckily in the last few years, the cost of genetic testing has gone down significantly in the last several years. So years and years ago, over 10 years ago, testing may have been a few $1,000s, even just for BRCA1 and 2 testing. Now, because the technology is faster, it's better, it's cheaper, now genetic testing can be performed through a large panel of genes. Again, all the genes that we've talked about, for an out-of-pocket cost of $250. There are a few commercial labs that are offering this, which has been really excellent, because It does improve access to genetic testing for patients without insurance coverage, or those patients who are motivated to pursue genetic testing, even if we don't see a lot of risk factors in their family for a hereditary cancer syndrome. And just one example here in Vitae, they do actually have their own self-pay option where it could be $250 for diagnostic testing. And this testing is different than the direct-to-consumer testing like 23andMe or Ancestry.com, which this test, like in Vitae and other labs, this testing is a clinical diagnostic test, but other direct-to-consumer testing like 23andMe and Ancestry.com is how I've heard it describe it as like cocktail genetics. It's something fun. It's, an Ancestry, there's nothing indicating that the Ancestry is inaccurate. If anything, actually it appears to be quite accurate, but it's not something that should be used for clinical decision-making. So just something to think about. So as an example, let's say Diana is a 36-year-old female. She's in good health. She comes in for an annual exam. She has Spanish ancestry. She reports her mom had breast cancer at 44 and passed away, but no other family history of cancer. And then Diana reports that she sent in a sample for genetic testing at 23andMe and that her results were negative for BRCA1 and BRCA2. So the question I have, and I was going to do a poll, but it wasn't working out. So I'm just going to pose the question for you to think about, and you can answer out loud where you are or in your head. Are Diana's genetic tests, is it informative? And does she need to be retested for BRCA1 and BRCA2 if her testing is negative? And let's say we actually have the report, it's confirmed. Does she need to be retested? Is this informative? And the answer is no and no. So 23andMe, it's not to say, so essentially what is important to know is that 23andMe, they do offer testing for BRCA1 and BRCA2, but only selected variants. You might remember I said that earlier in the talk, I said that there are 3 specific mutations that are seen commonly in people that are Ashkenazi Jewish. Those are the 3 variants that are being tested for. So for Diana, she may not have those variants, but she also has Spanish ancestry, so she would not have been expected to have those variants at all. And 23andMe does not do full gene sequencing of BRCA1 and 2, does not do deletion duplication. And those 3 mutations that are seen almost exclusively in people that are Ashkenazi Jewish make up only 3 of 1,000 known pathogenic mutations. So for Diana, this is a very uninformative test, and she would be recommended to have formal BRCA1 and 2 testing, gene sequencing and deletion duplication. And that's essentially what direct-to-consumer testing does. It looks at specific variants. And some of these variants may have a very small effect on health. It may have a very questionable effect on health. And it's not very clear for some of these variants, for even other diseases, how much risk it's actually giving. And it's sometimes not clear exactly how little of the gene they're actually looking at. So direct-to-consumer testing is, it is something that people do, but it's something that should not be used for any clinical determination. What some people have been doing is that they can take the raw data from 23andMe and actually upload it to programs like one called Promethease that actually builds a personal DNA report by looking at the genotype. So they actually can do that at not a large cost. But the problem with that is actually uploading these raw data files, there's actually a high false positive rate, because just in terms of how the data is uploaded and how the programs are, it can actually report a pathogenic mutation that if we test the patient clinically, the mutation is not there. So this is one figure from from this test, which actually showed that out of the number of patients that had pathogenic variant detected by uploading the raw data, 40% were a false positive. And you can see most of those were in genes that we often know about: BRCA2, BRCA1, ATM, MLH1 related to Lynch syndrome, CHEK2, TB53. So genes that, if someone had a mutation in those genes, that has clinical significance. So individuals, if they aren't aware of the risk of false positives, they may be doing screening or preventative surgeries that may not be indicated. So particularly with things like raw data and direct-to-consumer testing, if there is a family history and a patient is concerned, the best thing they can do is meet with a genetic counselor and have a clinical test for hereditary cancer. And there are position statements from the National Society of Genetic Counselors about at-home testing and things to consider. And the American College of OBs and Gynecologists also have a position statement. Actually say quite nicely in their title that it creates confusion. So direct-to-consumer testing, again, for ancestry, for small things like that, is something that, again, cocktail genetics, something that's fun. But for things like BRCA1 and 2 testing or anything else that's clinically indicated, definitely a clinical diagnostic test is warranted, particularly if there's a family history. So let's talk about, genetic testing and kind of what we talk about with patients. So when we do genetic testing, there are 3 possible results we can get from a test, which one will say positive, means there is a pathogenic mutation detected in one of the genes analyzed and that there are associated cancer risks. Negative, straightforward, means that when the genes are analyzed, there's no known pathogenic mutations. The genes look normal. There's no detectable hereditary cancer risk. And then there's the variant of uncertain significance, which is a variation in a gene that the laboratory has not yet classified to pathogenic, meaning it's causing cancer risk, or benign variation, meaning it's just a polymorphism that's actually not impacting the gene. And variants of uncertain significance, they're quite common, especially when we do larger testing, which we do nowadays. We actually find variants of uncertain significance 20 to 30% of the time. This is an example report. And particularly, it's always hard when you get a variant of uncertain significance in a gene like BRCA2, but most of these variants are reclassified by the laboratory to benign, to normal changes. That's why on the previous slide, if a variant of uncertain significance is detected, medical management is not based on that variant. It's based only on personal and family history factors. We have seen cases where someone is followed as if they have a real mutation in BRCA1, BRCA2, another gene that's actually a variant of uncertain significance, and they're screened. They may have preventative surgery, and then they find out in the future it is actually a benign variation. So we always go back to family history to guide management. It's something we kind of say innocent until proven guilty, because most of the time the laboratory will update us with a report when they can get enough information to change their classification. No, and actually I already talked about this, so I'm one step ahead. So really, I want to point out, we don't test relatives for variants of uncertain significance, only if it might be helpful in reclassifying that variant, meaning that sometimes it can be helpful to know, did the variant come from your mom or from your dad? Because your dad had pancreatic cancer and your mom is 85 and still living. So if this BRCA2 variant came from your mom, we might be less suspicious, but if it came from your dad, that maybe could add evidence, or at least keep it at the level that it is. So that's why we only really test relatives if it might be helpful in reclassifying the variant. And this can be hard for patients. It can be hard to have that uncertainty of, is this something I'm going to have to think about? Is this something that is actually going to, we find out that is positive in the future? And it can be hard to how to communicate this to family members. It's, it's some family members won't understand it. They might want to be tested for it. So this can be particularly tricky in communicating this with patients, which is why we do take time before and after, even before someone has testing, to prep them and let them know this is a possible result we can find that is quite common. And testing options they're all a little bit different. We do single site testing if there's a known mutation in the family and no other suspicious cancer history, meaning that there's a mutation we've confirmed with a report, there's nothing else. In those cases, we would test for just that single mutation. Other options for those families where there's not a known mutation is a cancer site specific panel, meaning related to genes that are only related to the cancer seen in the family, meaning that maybe if there's just breast or ovarian cancer in the family, limiting it to genes that have a known association with hereditary breast or ovarian cancer, or if there's colon cancer in the family, keeping it only to hereditary colon cancer. Expanded panels we've been doing more often, meaning that we look at multiple genes related to several types of cancer, including cancers we may not even be seeing in someone's family, such as colon cancer, melanoma, uterine cancer, stomach cancer. So essentially all the more common hereditary cancer types, we often can do that on what we call an expanded panel testing. But panel testing, there are considerations because the more genes we look at, the higher chance we'll find something in a hereditary cancer gene, which could be expected or possibly unexpected. Some patients don't want to find an unexpected result. As I mentioned earlier, there are some genes that are included in testing nowadays, particularly panel testing, that have not been studied as long. They have an unknown cancer risk. So there may not actually be screening recommendations. Because for syndromes like Lynch syndrome and mutations in BRCA1 and BRCA2, there are very clear screening recommendations. But some of these newer genes, we can find a mutation and still just follow someone based on personal or family history until we learn about what that gene is doing specifically. And as I mentioned earlier, that when we do a larger panel, it's probably a more standard panel that we do, we find a VUS 20 to 30% of the time. So that's quite a big chunk of the time. We find at least one. And so some patients may not want the possibility of finding an uncertain result. So something else to also think about when we offer genetic testing. Some of the benefits of genetic testing, it can end uncertainty. If there is cancer in the family, it can be helpful to know, is there a reason for why there's cancer in my family? And do I have the reason for the cancer in the family? It can clarify cancer risks for an individual, so then we know what screening we need to be doing. It can also clarify cancer risks for relatives. If there is a positive result, we then know that other relatives would be at risk of inheriting that same mutation, and then they can also have their own testing. And it can aid in medical decision-making, knowing, again, what screening they should be doing. Is it worth thinking about a prophylactic bilateral mastectomy? And that can actually relieve anxiety. There are studies showing that even a positive result can actually be anxiety relieving because someone actually has the answer. They actually know why there's cancer in the family, what's causing it, and they know the specific risks instead of an unknown. There are some risks and limitations to genetic testing, such as a negative result may be uninformative or it may be falsely reassuring. There are concerns about genetic discrimination. So there are laws in place that do make it illegal for most health insurance companies and most employers from discriminating against someone with a positive genetic test result. But these do not apply to things like life insurance, long-term care, and disability, and it actually possibly could impact fitness for duty in the military. So it is something to think about when someone has genetic testing, what policies they have in place. Are they actively serving in the military? Just to think about. And timing of testing might not be optimal depending on someone's current lifestyle or current plans. And genetic testing is an option, even though there are clinical recommendations, it is an option. And for some patients, they actually prefer not to know if they have hereditary risk of cancer, and they may not wish to know future cancer risks. There are limitations in the testing. So It is possible, even though the testing technology has grown a lot, there are sometimes undetectable mutations in current technology that could be missed in a known hereditary cancer gene. Testing technology will change and improve over time, just like it has in the last 10 years, but that is a limitation. And not all inherited cancer syndromes are known. So in the future, kind of like I mentioned with BRCA1 and BRCA2, before 2013 is outdated. It's possible I could be saying in, 2030, if any test before 2033 is outdated. We are likely to learn more about inherited cancer syndromes and new genes. So more testing may be needed in the future to help clarify risk for some families. And this is an example of an informative genetic testing where the proband, where the circle the arrow is pointing to, she's had negative genetic testing, but has a very striking family history. So her testing is really not informative, and it's not someone that you'd feel comfortable saying, oh, you are at average risk for cancer. We always go back to family history. This is why we go back to family history to guide screening until we can get an informative relative tested and determine, is there a familial mutation that maybe this proband did not inherit? Which is why, again, it is very important for sometimes testing the affected relative first. And if that relative has had genetic testing, it is really important for you to be talking to your patients and explaining it is important to get those medical records for us. And genetic counseling in the session, what I do and what my colleagues do, it's really a combination of education, talking about the diagnosis of hereditary cancers, syndromes, offering psychosocial support, advocating for our patients, talking about risk. So it is really this, we're here for a resource for patients. We're also here for a resource for you, in terms of risk assessments and patients going forward. I'll go through some of this briefly because I don't want to go over too much over time. But there's a lot in a genetic counseling session where we go through medical history, we take a detailed family history, we talk about the risk factors we see in the family, we do a risk assessment, we talk about specific genes or specific syndromes the patient may be at risk for. We talk about, what hereditary cancer is, why we do testing, what screening would change if someone was positive, why are we doing this testing at all? We talk about different testing options in terms of limited panels or expanded panels. There's research, of course. We coordinate the testing, we call the patients with their results, explain the results, and then do any follow-up in terms of referrals to specialists, and also just be a resource for the patients for information. So for what you can do to help have your patients prepare, probably the most important thing is to encourage your patients to collect their family history. So if you place a referral for cancer genetics, the most helpful thing is for that patient to be talking to relatives, getting that information. Particularly if there's a known mutation, it's very important to have that confirmed with records. It actually can impact the accuracy of the patient's own testing, which some patients may not understand. There can be differences in laboratories in detecting specific variants. So if we cannot confirm what lab or what specific variant a relative had, it's possible the patient could get an uninformative or even a false negative result. So any medical records from relatives, any information is very helpful. Which bring those medical records to the visits, and again, just encourage them to get copies of any genetic test results. So after the referral, it takes about the initial genetic counseling visit is 60 minutes. They are sent a questionnaire, and the patient schedules an appointment. They do a very brief intake. Again, the initial genetic counseling visit takes about 60 minutes. We, again, go through that whole session, and the cases are reviewed at our weekly cancer genetics and prevention program, just out of a meeting where we review all the cases all together. Patients are disclosed the results over the phone or in person if the patient prefers, and the patient does get a copy of their results and a detailed summary letter. So I'll just end this by saying, you don't have to be the experts on hereditary cancer. We're here for a resource for you. You're really, the front line for these patients to really gauge their personal and family history. So I really just, that's the last thing I'll say. And I thank everyone for your attention. And it was a pleasure talking to everyone, and I will take any questions.
Great, Amy, thanks for a great talk. That was really, you managed to pack in a lot there, so thank you so much. I do just want to let all of the attendees know that the session is being recorded, and a link to the recording will be on our website. So if you want to go back and listen to parts of Amy's talk, you will have access to that in the future. We also have a number of resources on our website, including fact sheets that you and your patients may find helpful. So encourage everyone to look at the website, and I believe that the website will be included in post-conference communications. So we'd like to encourage people to enter some questions for Amy in the Q&A, and Amy, we do have a couple here. So the first question we have is whether Gardner syndrome is something separate, or whether that actually is attenuated polyposis.
Great question. So Gardner syndrome is, I would say, it's an outdated syndrome. It was mainly used to describe if someone had specific, less common features that we would see with classic FAP. But we know now that people with Gardner syndrome do have pathogenic mutations in APC. So we really just prefer to call it FAP or attenuated FAP. So it's not, so I would say, to answer your question, they are the same. They just that Gardner syndrome was how certain phenotypes were described, particularly some of the less common features of FAP, like extra teeth and things like that, oftentimes was described for Gardner syndrome. But nowadays it is packaged together. But that is an important point, that some people still use some of the older terminology for Gardner syndrome. So if someone does report a family history of Gardner syndrome, even though that may not be a term we use currently, that would also warrant a referral.
And the next question we have is an interesting one. There's an attendee who's wondering if we think the ages at the time of diagnosis are getting younger in subsequent generations. So for example, if someone's mother had breast cancer at 55 with a BRCA mutation, are we seeing her daughter, who has a mutation, having her breast cancer earlier in life?
That's a great question. As with BRCA1 and BRCA2, and we often call this in genetics anticipation, where the phenotype appears to present at a younger and younger age. There's no known evidence of anticipation in BRCA1 and BRCA2. It's hard to say, but there can be what we call variable expressivity, meaning that someone could have the same mutation in BRCA1 and BRCA2, but they will not always develop breast cancer at the same age, or even develop someone may develop ovarian cancer or breast cancer, which we call variable expressivity. So that might explain why in some families it does appear that a mother may have breast cancer at a later age and her daughter has breast cancer at an earlier age, not because of something like anticipation, but possibly due to that variable expressivity. Though I do know that there was some older data, I think Claire, you mentioned this to me a few years ago, where there's some data suggesting maybe anticipation with Li-Fraumeni syndrome, where individuals actually appear to develop Li-Fraumeni syndrome associated cancers, particularly breast cancer, at younger age and subsequent generations. In terms of additional research on that, I have not seen anything recent about that, but I know there was some hypothesis that Li-Fraumeni syndrome may have some level of anticipation. But in terms of other hereditary breast cancer syndromes, there's none that we know of yet.
Yeah, and I would just add that even with these hereditary cancer syndromes, the mutation is not the only contributing factor to cancer risk. Lifestyle, environment, all of those things still play a role in cancer development. And so it's possible that some of those earlier cancer diagnoses that you're mentioning are related to other factors outside of the genetic mutation or in addition to the genetic mutation. And I think we still have a lot to learn about hereditary cancer genetics. We've come a long way, we know a lot, but we'll learn more. And perhaps some of these hereditary cancer syndromes do in fact have anticipation and we just don't know yet. Those are all the questions that were entered into the Q&A. So I don't know if any of our panelists have any questions or if we want to give people just a minute in case any other questions come up.
Maybe while waiting, I'll pose a question. Amy, that was a great talk. So quick question, you went over very nicely about what happened with BRCA and why people got retested, and then towards the end, you also discussed a little bit more that there may be some in the future opportunities for bettering the testing and actually being able to detect a few more than before. So when do you think people will have to consider resending a patient who previously had tested negative? I'm talking in general terms. What do you think would be a general recommendation that we could follow in terms of that?
That's a great question. It's something that patients also ask me even now. They say, well, when should I call you, for more testing? I think it's hard now that testing has gotten so comprehensive, I would say so quickly, even the last 5 years. What I've been saying to patients, and this is not something that's really a hard and fast rule. I would say at least 5 years to check back, unless there was a change in someone's family history, like a new cancer diagnosis that possibly could mean that other genes related to that diagnosis were not included in the testing. But if there's no changes to someone's personal or family history, I would say every 5 years is a good place to check. And it's possible even in 5 years from now, maybe it might not change as much, but I can't imagine the testing jumping to such a huge amount of clinical significance in less than 5 years. I don't know, Claire, if you have any other thoughts on that in particular.
No, I agree. I mean, I think the testing technology it changes quickly, but not that quickly. So 5 years is probably a good estimate. But I would also just reiterate one other thing that you said there. If the personal or family history changes, that's another really important touch point for patients to get back in contact with us, because that could certainly change things. So those are good time points to consider reevaluation. All right, I think that's it for questions. So Amy, thanks again for your talk, and we hope that everyone will join us next week for the second half of this seminar series.
Thank you, everyone. Have a good night.